First of all, I'd like to thank the Ordinary Committee for giving me this unique opportunity. So today I'd like to talk about therapeutic approach for ovarian failure. Here is my COI. Premature ovarian insufficiency, POI, diagnosed by amenorrhea before 40 years of age, and hypogonadotrophic hypogonadism. These patients showed infertility and symptoms caused by estrogen deficiency, such as hot flashes, mood disturbances, sexual dysfunction, etc. In terms of etiology, POI affects approximately 1% of women. Concerning etiology, POI affects approximately 1% of women, and it's caused by genetic abnormalities. Most famous one is Turner syndrome, and genetic abnormalities in FMR1 gene are also reported. And some patients have autoimmune antibodies, but their exact role is still unknown. As for iatrogenic one, the chemoradiation therapies can cause an POI, and also the extensive ovarian cystectomy and partial oophorectomy also can cause an POI. But half of them are still the causes unknown. The specific features of POI are lacking of follicle growth and ovulation, and exhaustion of ovarian follicles. The patient should have less than 1,000 follicles. That's why if we try to measure the AMH levels, almost all the patients show undetectable levels. Because of these specific features, patients are really resistant to traditional gonadotropin treatments. And thus, egg donation is the most successful treatment option. Actually, this is the only one established way to conceive the POI patient. But, the patient really would like to conceive their own genetic babies. Then we have that is it possible to activate residual dormant follicles in a POI patient to develop new treatment? Primordial follicles are dormant in ovaries. Some growth factors such as KIT ligand, neutropin, BMP, BGF, LEAF, etc. have shown to activate primordial to primary stage. Among huge number of dormant follicles, up to 0.1% follicles are selected to activate per cycle. Because POI has less than 1,000 residual follicles, these growth factors can activate theoretically only one follicle. So it's almost impossible to use these growth factors to activate dormant follicle for clinical setting. So then we focus on an intracellular signaling system involving the activation of dormant primary follicles. Using knockout studies, Reddy and Casaridon reported similar phenotype in P10 knockout and FOXC knockout mice. So as you can see, at day 5 after birth, there was no difference between wild type and P10 knockout, but at day 35 after birth, in the P10 knockout, the ovary became bigger and you can see multiple growing follicles inside. They originated from the spontaneous activated primordial follicles. So that's why at 6 weeks after birth, in a control group, there was still follicular genesis. You can see the different stage of growing follicles, including corpus luteum. But in a P10 knockout, almost all the follicles are depleted, and ovary became shrunken. Well, look like a POI ovary. And completely similar phenotype could be obtained in FOXC knockout mice. So this similar phenotype could be explained by the PI3K signaling pathway. This pathway begins the PI3K activation by receptor tyrosine kinases after binding growth factors. The PI3K activates KKT, which inhibits the activities of FOX3, resulting in cell proliferation and survival. The P10, this molecule, negatively regulates the PI3K signaling pathway. So in primordial follicles, local factors activate dormant follicles through this pathway, whereas P10 acts to block the signaling. So then we have that is it possible to activate residual dormant follicles in a PI patient artificially by transient P10 suppression and or PI3K activation using some kind of drugs? We have P10 inhibitor and we have a PI3K activator. Using these reagents, we succeeded to activate dormant primordial follicles in mice and a human by culturing ovarian cortical fragments. After confirmation of safety using mice and a monkey, we have conducted a clinical trial. Briefly, the first step is ovariectomy under laparoscopic surgery, and then we can culture ovarian cubes with PI3K activators. Then we are going to perform autotransplantation under laparoscopic surgery again. We can also cryopreserve the ovarian cortical tissue. Now we are using the vitrification method, and during cryopreservation we can confirm the presence of the residual follicles by histology. And after transplantation of ovarian cubes, we treat in a patient with very specific ovarian stimulation, and then we can do the regular IVFET treatment. Here, I removed the one side ovary and dissect ovarian cortices containing residual follicles by removing medulla, and then cut into small stripes around 1 cm square with 1 to 2 mm thickness where residual follicles are located. And at this moment, we can do the cryopreservation by vitrification method. Then usually we can obtain 6 to 8 pieces of ovarian stripes from one pure ovary. And using 10% of volume of each ovarian stripe, we try to detect residual follicles under histology. Then we fragment ovarian stripes into tiny cubes around 1 to 2 mm square, and then put onto the membrane of the cell culture insert, and then covered by a very thin layer of the media to allow to do the tissue culture, and cultured with IV drugs, P10 inhibitor and PI3K activator for 2 days to activate dormant follicles. For autotransplantation, we cut a serosa and making a pouch between serosa and the fallopian tube, and we grafted multiple ovarian cubes beneath the serosa of the fallopian tubes. And wound was covered by oxygenized regeneration cellulose to avoid cube loss from the grafted site. Of course, you can make a suture to avoid the cube loss. So we named this approach as IVA, in vitro activation, and succeeded the first baby after the IVA in a PI patient. After our success, other teams in the different countries could repeat our IVA treatment. So this slide shows the temporal follicle growth in transplanted ovaries. Because it takes around 4 to 6 months from primordial to preoperative stage in a human, so we expect to have a follicle growth in a patient after an IVA at 4 to 6 months. But in contrast to our expectation, not all the patients, some patients could have a follicle growth before 6 months. So this result suggests our IVA method also stimulated growth of secondary follicle in grafted ovaries. How could activate when the primordial follicles grow into the preoperative follicle in just a few weeks? Then we have said that are we unleashing the growth and potential of arresting the secondary preantral follicles after ovarian fragmentation in PI patient? What is the mechanism behind? Then we try to graft the paired ovaries from datum mouse, which consists from the primordial and secondary follicles, with or without fragmentation. and grafted into the echinoid capsule of other ovary-optimized mice. As you can see, at day 5 after grafting, we measured ovarian weight and realized the ovaries cut into 3 pieces became heavier than the intact ovaries. And we further performed histological analysis and found the proportion of the late secondary and antral preoperative follicles were increased in the group of the ovary cut into 3 pieces as compared to the intact ovary. Well, now we understand the cutting into pieces, fragmenting ovarian cortex can stimulate the secondary follicles. But what is the molecular mechanisms behind? So due to a shortage of time presentation, I cannot tell you the detail, but here I summarize all the molecular mechanisms. So the ovarian fragmentation led to a change in intercellular tension and facilitated the conversion of G action to F action. And this action suppressing the hypothalamus pathway allow YAP going to nuclei, and this YAP occur with TEAD transcriptional factors to produce senescent growth factors and anti-apoptotic factors. And these growth factors can stimulate secondary follicle growth. Now you know, in an IV approach, there are 2 steps of follicle stimulation. One is activation of dormant primordial follicles to be primary stage by PI stimulation. And the other one is stimulation of secondary follicle growth by hyposignaling disruption. Then the important question is it safe to use an IBA for oncofertility patients? Actually, we cannot exclude the possibility of the activation of malignant cells existing in ovarian tissue by this PI3K activated treatment. So I believe the establishment of more safe approach will be needed for the oncofertility patient. During IVF, we experience the patient with POR. Actually, we usually use Bologna criteria to diagnose POR patients. As you know, the chemo and radiation therapies can cause POR status. Okay, here's the Poseidon classification. Among POR patients, the patients classified into groups 3 and 4 show diminishing ovarian reserve and ovarian dysfunction. Then we try to develop a new IV approach targeting immature secondary follicles. In diminishing ovarian reserve and early POI patients, they still could have a spontaneous activation of dormant primordial follicles, but few antral follicles. Then we have that is it possible to stimulate residual secondary follicles to increase the number of the antral follicles by disruption of hyposignaling only. In our original IV approach, because of the 2 days culture of the PI3K activators, we need to perform 2 times the surgeries. But in the case of the DOR and early stage of POI patient, we can only remove the part of the ovarian cortex because they should have much higher number of the residual ovarian follicles in the ovaries, and then fragment into tiny cubes and immediately return. And that requires only 1 surgery. Here I'm going to explain our scheme of IVF for infertility treatment of oncofertility patients. Okay, in cancer patients, we can perform ovarian tissue cryopreservation before the gonotoxic chemo and or radiation therapies. And then, after remission of original cancer, we saw the cryopreserved ovarian tissues, and then we performed the drug-free IBA. If the patients do not accept fertility preservation, we can perform the drug-free IBA when the patient becomes DOR or REPRI after remission of the cancer. So we named this approach drug-free IBA. Actually, this drug-free IBA only applicable to the DOR, RE stage of PI patient who likely to have residual secondary follicles. But there are some advantages. Minimum damage to the ovarian blood supply, no need to use an AKT-stimulating drugs, avoid potential follicle loss during culture, one laparoscopic surgery will be needed, and if you return to the remaining ovary, we can expect even a spontaneous pregnancy. Then we perform the clinical trial. Here the patient characteristics. So you can see the median of serum FSH level in 11 patients was 47.3, and serum A2 levels 0, serum AMH levels 0.04. Here, we would like to demonstrate our procedures. For drug-free IBA, procedure consists from the four steps. For drug-free IBA, we remove a plate of ovarian cortex from one or both sides of ovaries, depends on size of ovaries. As shown in the picture, we try to remove the ovarian cortex only where residual follicles are existing to avoid bleeding from the ovary. The step 2 is cutting ovarian cortex into small cubes. The ovarian cortical fragments were further cut into small cubes, around 1 to 2 mm in the tissue culture medium without PI3K activators. The third step is making pockets beneath serosa of fallopian tubes and between ovarian cortexes and medulla using extremely fine membrane forceps. The last step is grafting ovarian tissue cubes into pockets. Using a device developed for tissue grafting, we graft ovarian cubes into the tunnel between ovarian cortex and medulla. Then the grafting site is covered by interseed to avoid tissue loss. The post-surgery follow-up is really important for successful pregnancy. We developed an original method for ovarian stimulation in patients with high gonadotropins and undetectable estrogen levels. Here, I'd like to show growing follicle number before and after the IBA. The number in the left side box indicates mean number of the follicle under ovarian stimulation before the surgery. Each arrow indicates the follicle growth after the surgery, and the number in the oval indicates the number of the growing follicle in each cycle. Red color means increasing in growing follicles, and blue color means the number of the growing follicles under natural cycle. For example, the patient 2 had a 0 or 1 growing follicle before the surgery, but she could have 6 to 8 growing follicles per cycle under ovarian stimulation after the surgery. Among 11 patients, 9 patients could have an increase in growing follicles. Here, I'd like to show the current clinical outcome in drug-free IBA. When we published the first paper in 2019, the success pregnancy was achieved in 4 out of 11 patients who failed pregnancy by more than 2 times of previous IVF cycles. And then 3 patients who have prolapsed embryos are waiting for the embryo transfer. And when we published the second paper with 4 additional patients from the first study, the success pregnancy was achieved in 40% who failed pregnancy by more than 2 times of previous IVF cycles. And this is my last slide. These are my collaborators, and I especially thank Professor Aaron Schwein, Stanford University, for long collaboration to establish this new IVA treatment. Thank you for your kind attention.